Hello, this is Dr. Carrie Bedient with the Fertility Center of Las Vegas, and I am joined by my two sparkling co-hosts, Dr. Susan Hudson from Texas Fertility Center
Hello.
and Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody.
How you girls doing?
We're doing
Doing
great.
great.
Yeah? What have you been up to this weekend? Anything fun and exciting and
I went
witty?
shopping.
Ooh, what kind of shopping? House shopping, clothes shopping,
Uh,
kid shopping, stuff shopping?
Car
Clothes
shopping.
shopping. Clothes shopping. I have two weddings that I'm going to this fall.
Ah.
And so I decided to go get a nice new fancy dress. And so it was
Ooh.
pretty cool. It was pretty
So
cool. We went
what's
to
it look
so I went to Neiman Marcus last call at our outlet mall.
Oh, yeah.
I love bargain shopping, but I have to bargain shop at like places that are spread out enough. Like I can't walk into a store that's all cluttered.
Yeah.
It puts me on information overload and I look through and walk out with anxiety. So
Oh, no, Susan. That is fun to dig through everything and find the really expensive, well-made outfit that you get for like 50% off
it can do
50%.
that and be organized and not make me claustrophobic. like I
Oh,
Yeah.
like I love shopping at Soma. Like I can go to like a normal Soma store and walk out with something. I walked into our Soma outlet literally 5 times, like with very intentional. I went to buy like a pajama top and I cannot make a purchase. I am like struck with like immobility at
see,
lack of
that's
organization.
that's your problem. You've got to walk into a store like that going, what bargain can I find? It may
Oh,
be a
I
pair of
love finding the
shoes.
bargain. I mean, I'm the
It may
person, if
be a
I can
top, it
negotiate
may be a
price,
dress. You just have to let the world open up to you and let the store give you what it's got. You can't go in with like, I've got to get this or that. Because when you want to buy something, you can never find it when you need it.
but
So
yeah, well, this is one of those times I had to go find something specific. So we went in and I went shopping with my daughter and we pulled like 10 things off the rack and we go in the dressing room and I'm like, pick which one you want me to try on first. And I tried on the first dress and it was like, oh.
oh, that's cool. That usually doesn't happen with dresses.
And then I tried on the other 9 and it was just like, but it's blue and it's strapless. And it was literally like when we put the zipper up, I was like, it fits perfect. Like
Well,
That's
and
awesome.
nobody
tighten
can
all the
see
right tight
Susan.
places and loosen all the loose places.
Susan's tall with this long, thin body, so there's not too much I think that would not look good on her. But I think probably all those 9 dresses looked really good. But that's cool. Blue's really pretty color. I like
It
royal
was
blue.
it was really it was fun. It was one of those dresses that I mean you have to have a kind of fancy event to go to, and
Yeah,
I haven't gone to it, with COVID and everything like that. I
yeah.
mean, all the like fancy stuff we used to go to, I haven't been to anything in 2-3 years, and so I was like, need a new dress. So it was fun. Now I got to get shoes.
I had a nephew that got married about a month ago, and I was kind of like you. I was like, I want to wear just a really, it wasn't a long dress or anything. It was an outdoor wedding, but kind of a fancy dress. And so I don't know what hit me, but I decided I was going to wear a fascinator with the dress, and I couldn't find
Nice.
one that matched the dress. So I used my skills of color matching and color mixing and mixed up color and like just painted the fascinator. It actually looked pretty good, I thought. So
That's cool. That's
so
what I was watching I think I was watching Sweet Magnolias. Have you all seen that series?
uh-uh.
Okay.
Mm-mm.
Love the series. Very cute. But they were having a funeral / celebration of life for someone in the town that had passed away. And it takes place, I think, somewhere in the South, like Virginia or somewhere like that, and they were all wearing fascinators. And I was just like, oh, I hope this becomes a big thing in the US.
I have to say I felt a little bit dorky wearing it, but I'm like, I'm just going to do this. I want to wear this fascinator, and I think it looks good. And a lot of people came up and commented on it, and I stood out whether I wanted to or not.
It's just a cool name for a hat.
Yeah, I like
Yeah.
it.
For any fashion item, like if you walk into something wearing a fascinator, it means you are the most fascinating person there. And so it seems appropriate for you to wear.
Exactly.
Well, I think it's back from my days when I lived in Louisville and did my fellowship there. I got used to once a year we'd wear hats to Oaks and if
Derby.
you went to Derby. So yeah.
Yeah. Yeah. All right. So let's bump into our topic. And what we're going to go through today, we have a ton of questions about really what's the next step. Things didn't go the way that we wanted to with our IVF cycle. So what do we do now? So we're talking a little bit about what are next steps. What do you do with the failed transfer? One of the things we noticed about these questions is there's a lot of nuance in them. And so it's part of the reason where some of the stuff we're going to talk about, we have talked about before, but some of them are more of the kind of the very subtle things that we pick up on. We're like, well, maybe we do this. So not the concrete hit you over the head things, but just well, maybe you try this kind of things.
I love the art of medicine.
Yes.
Yes.
The art of ART.
Yes.
So,
The art of art.
yes. All right,
All right.
Susan, what you got?
Okay. Hi, ladies. Love your podcast. My husband and I have been trying to conceive for 2 years. Listening to your episodes has been really helpful, especially over the very difficult last 6 months. My question is, what additional tests would you recommend or other options we might have before IVF? They've had all the normal tests done twice by their RE and OB-GYN. Everything's normal. 2 semen analysis and HSG normal. She's 30 with unexplained infertility and has been very frustrated. They've done 3 Clomid only cycles, 3 Clomid and IUI cycles, and a letrozole gonal F progesterone IUI cycle with the REI. Can't rationalize spending any more time or money on failed IUIs, even though my doctor said I've had several really good follicles. Are there any other tests we might not have done yet? Anything else you could recommend before we jump into IVF, which seems like our next best chance? The cost of IVF is not something that will be easy on us right now, but we're both ready to start a family and feel like I'm close to my breaking point after the 4th failed IUI and 2 years of being in limbo. Any tips or advice would be greatly appreciated. Thanks.
I would make sure that there's a good intrauterine evaluation. HSG is great for tubes. I'm assuming with your REI, you've gotten all of the egg testing done and that they've got a good idea of dosing from your prior cycles. Like that's probably in place. I think a good uterine evaluation, saline sonogram, hysteroscopy, or both is probably one of the things you for sure want to do before you hit a transfer. Doesn't really matter before retrieval, but for sure before transfer, I would do that.
Yeah, I mean, it's tough because there's just not a lot of tests to do anymore. It's interesting over the course of my career, there's less tests that we do now than we used to do before. We know that sperm penetration assays don't really tell us anything. Antisperm antibodies don't really tell us anything. And so, and I think we all 3 get that a lot. Like, okay, well, you've done these tests. Well, what are the other tests? I'm ready to do those. And unfortunately, there's just not a lot of other tests. There's millions and millions of things that probably have to happen for an egg and a sperm to get together. And, I think at 30, the good news is you're young, but you've also been at it for 2 years and, you're ready to have a baby. And so I think a push towards something more aggressive is probably the right answer, even though we don't really have any tests to look and say, kind of what the problem is. We know that IVF is more successful and you want to be pregnant. You don't want to just spend your life doing tests.
Yeah, I completely agree. And one thing to remember is that when you're doing IUIs, your best chances are in your first 3 cycles. After that, it doesn't mean you can't conceive, but it means your success rates have really started to plateau. And so, there's some people who would choose to do more. But, if your ovarian reserve is good and you need to take 3, 6, 12 months to save up for IVF, so that you can do it in a kind of financial situation that isn't going to add as much stress on you, I would take that opportunity. It is one advantage of trying early and having a little time on your side.
One thing that I would consider, because you mentioned how the stress of the failed IUIs is hitting you, I would definitely make sure you have some sort of support group going into this, because IVF is difficult and any fertility treatment is difficult. And so having really someone else who's totally impartial, who's not your spouse, or your best friend say, this isn't your fault. You can't control this. And focusing on the ways that you can survive to get through this, it can be really helpful. And so it won't necessarily cure the pain, And this applies to both physical and mental pain for whatever is causing it, but it won't necessarily cure the pain. But if it can help you live with it without being driven to distraction, that is very worthwhile.
Yeah,
Good
absolutely.
advice. Good advice.
All right. What you got next, Susan?
All right. I'm 37 with secondary infertility due to bilaterally blocked tubes, AMH 0.98, have always had regular cycles. Got pregnant with my 2-year-old son within 8 weeks of trying. So my husband and I knew pretty quickly that something was off. I just finished my first egg retrieval and got the following: 8 eggs, 5 mature, 4 fertilized, 1 day 7, 6 BB blast, PGT pending. My question is, if we had to repeat the egg retrieval process, should we modify the med regimen? If so, how? And is there anything else I could do to optimize egg retrieval if I have to do this again? I'm pretty healthy non-smoker with normal BMI. Medication included Gonal-F and Menopur, Cetrotide antagonist, dual trigger with Lupron and HCG shots. So in general, I mean, there's even nuances amongst what you described.
Mhm.
Okay.
Yeah.
So, when I'm looking at somebody who has diminished ovarian reserve, I like to do something like an estrogen priming protocol, make sure you weren't on birth control pills to suppress you in that way, to give you a little more lead off. I always say that it lets your ovaries take a nap before you start your stimulation, so that they're like, woohoo, we're ready to party. So we want partying follicles.
Yeah, I think that's, I would agree with that. I like the priming protocol. Sometimes a Lupron flare protocol can be really helpful. I like those a lot in the right patient. And it sounds like from the number of eggs that you got that you might be an appropriate patient for that type of protocol. The other thing is looking at some of the nuances of the levels that your REI is going to have. You know, what was your absorption of your FSH on day 4? What was your response E2 wise, estradiol wise? Like, how is there anything that they can go up on for that can make a difference? Sometimes adding Clomid to a cycle can help. A lot of it is trial and error and saying, okay, did we really like the results we got from that cycle? If not, maybe we want to try something different. But those are some of the
So
things I would think about.
did she mention what her AMH was, Susan?
0.98. So a little bit
0.98.
low.
So, yeah, I mean, if you were my patient, I would say, yeah, we would like to do everything we can to get more eggs, because the more eggs we can get, the better chances we have one to test and one that's normal. Quite honestly, what you got, in my opinion, 8 eggs is pretty good for 0.98. And to get one blast to test, trust me, we all want more, but that's not really that far off of normal for you, I would say. And so, but along those same lines, I agree with Carrie and Susan. I probably would just try and go up on the medicine, the total dose, to try and push you a little bit harder. I think estrogen priming works great, particularly if you had one that was sort of ahead of the pack, more of like a dominant follicle. And a microdose Lupron flare is a stimulation that we used to use many years ago, and it capitalizes on your own endogenous estrogen or FSH that you make. So your brain kind of gives you FSH, your own endogenous FSH, and then we give you a bunch of FSH on top of that. So it's almost like a 1-2 punch. So that might not be a bad idea to see if maybe your ovaries could be coaxed to really try and make more eggs.
So a couple of things. If you're wanting to do that flare because you did a Lupron trigger, you're probably gonna have to wait 3 months, because it takes 3 months for those receptors to turn over. Couple of things I saw: 5 out of 8 mature. I think that's a little bit on the low side. I mean, we're looking for perfection. And so, if you did go down that path, or even without, I mean, when you're getting 8 eggs, your chances of hyperstimulation syndrome are pretty low. So as somebody who loves the good old Lupron trigger, I would probably do a higher degree of HCG trigger. And then the fact that you only had 1 blast on day 7. Day 7 embryos, though they can make beautiful, wonderful babies, do have less degree of competency. They're less likely to result in pregnancy as compared to a day 5 or day 6. I usually consider day 5s and day 6s relatively equal. And then we see probably about a 15 to 20% drop on day 7s. And so that to me kind of points to potentially a machinery issue within the egg or embryo, most likely. And so making sure you're taking some vitamins like CoQ10, DHEA. Data is mixed. Beliefs amongst the three of us are mixed on this one. But growth hormone might help improve how your embryo is actually acting in the lab. So it would be something to consider. It is not a miracle, but it is something that might have an effect.
One more thought, and kind of subtle here, but you were saying the fact that you had 8 and only 5 were mature. What that really kind of says to me is, in a 37-year-old with a abnormal AMH, is that your doctor was really trying their best to scrape out every little egg that might be there.
Mhm.
So what that says to me is, there might have been some really small follicles that they were just trying their best to get the egg out of, and that's why the maturity wasn't quite as good.
Yeah. When you look at the fact that there were 5 mature and then 4 fertilized, that is a good ratio.
That's good
So,
fertilization.
Yeah.
so I was kind of thinking what Abby was thinking of. I bet they were going for absolutely everything they could get, and they
Doing their
probably got
best to get
some
those
babies
eggs
in there, and getting them in the hopes that they were mature, because the small ones can become beautiful babies. It's just statistically they are far less likely to, kind of in the same way that the day 7s, if they make the baby, it's great, but they're just less likely to make the baby.
Mhm.
All right. What else?
Our next one. Thinking about getting a second opinion. 33 years old, IVF process started a year ago. Both partners are carriers for cystic fibrosis. PGTA and PGTM testing done. First egg retrieval resulted in 2 unaffected embryos. Second egg retrieval resulted in 4 unaffected embryos. 2 are mosaic. They have an unbalanced translocation. ERA performed. We also have an unbalanced translocation. ERA performed before first transfer, good. M2 testing for me and my husband, both negative. Transfer in February failed due to bad luck. Performed a thrombophilia panel. So far looks good. Found out yesterday the second transfer failed. Have not spoken to doc directly yet. Doc said that success on transfer is 80%, which seems high to me. What else can we test for? When do you know it's time for a second opinion? Should we do another transfer first or egg retrieval to bank?
What's age on this patient, Susan? Did she say?
33.
33. Okay.
So I'm a little confused. So there's 6 that were unaffected, but they're also carriers of a balanced translocation too?
Yes.
That's
Which
awful lot.
That's awful. Because we typically say, I believe 30% chance of having an unaffected embryo if you have a balanced translocation, but it's hard to tell with PGTA whether it's balanced or not.
Well, it depends on how the PGTA is run, on what type of platform.
And 30% for good embryos is so wildly variable. I mean, I know the genetics counselors that we work with, like they give kind of a more vague percentage in terms of, it's really hard for us to know what percent are going to come out normal versus not.
So what I'm hearing is, I think a good, first of all, none of us are genetic counselors. Unless I'm wrong, none of y'all actually have a degree in genetics.
No.
I certainly don't. Okay. So although we know a lot about genetics, this is so complicated that I think you need to have a very good, solid sit-down discussion with a genetic counselor to fully kind of understand and probably a genetic counselor associated with the company that you did your PGT through, because then they're very specific to that platform as to what is the kind of sensitivity and specificity of that test for balanced translocation. But I do have to say, an 80% success rate on an embryo transfer, that's
high.
That's a really high promise to give somebody. I mean, I like to think we're good, but that's, I'd love to be 80%.
She didn't make a comment about which ones are balanced and which ones are unbalanced. So I'm guessing they didn't know when they transferred which ones were balanced and which ones were not.
Well, no, I think they did PGTA, so they would have seen the unbalanced ones there.
Okay.
Yeah.
They may not have seen the balanced ones, but they would have seen the unbalanced. I think the 80% success rate is not necessarily pie in the sky. Like, I think That to me, based on our rates, makes sense. But it's also because if you have a center that is very selective on the embryos they are willing to biopsy, it means that there's been a lot of selection already done. And so in the right circumstances, I can see that. But I think I agree with Susan. I think you get really good genetic counseling on all this to see the impact of, talk to them about the mosaics. Many people will not transfer a mosaic, but there are some people who will.
And there's going to be more and more people that will. I would
Yeah.
also recommend like a hysteroscopy. You've had two
Yeah.
transfers of chromosomally normal embryos, and we know there's a pretty good study. Gosh, that was probably 10 years ago that came out that said that if we transfer essentially two untested embryos, that 30% of those people who have had a normal saline ultrasound actually have pathology in their uterus. So the fact that you've had two chromosomally normal embryos transferred, you need to have direct eyes on the lining of your uterus.
Yeah, there are things you can't see with just the general test we do before a cycle.
Mm-hmm.
Okay. All right, what's next?
All right. I want to start out by saying how much I appreciate your podcast. Thank you. I'm 35. In 2021, my day 3 lab showed AMH of 3.2, FSH of 8.2. When repeated in 2022, AMH was 1.6 and FSH was 9.5. We have done 6 IUI cycles with letrozole and 1 retrieval. My stimulation was follistim and Menopur 150 with Ganirelix, triggered with Lupron and Pregnil. Stimulation cycle was 9 days, and at the time of trigger, I had about 21 follicles. 1 at 19, 4 at 18, 5 at 17, and the rest at 13. We're able to get 5 mature eggs and 2 M1s, 5 fertilized, 3 stopped growing at 11 cells, and 2 never grew. How common is no blastulation? What protocol changes would be helpful next time? How likely is it to get no embryos next round? Any advice is appreciated.
So 21 follicles and 5 were mature. Is that what she said?
Yeah,
Yeah.
but listen to the sizes.
The sizes are pretty
119
small. 1 is 19, 4 at 18, 5 at 17, and the rest are 13.
Yeah.
Carrie's let me guess. Carrie's gonna say your follicles
Go
need to
further.
grow for at least 2
Yeah.
more days.
I would say so too.
minimum. Like I would push it longer. Like
Yeah,
you
I
need
think
at
that
least
makes
2 more days.
that makes a big difference, I think, to have
I
bigger
mean, and
follicles.
she only stemmed for 9 days, and
Yeah.
I can't
Yeah.
remember the last. I mean, unless I had somebody with really bad diminished ovarian reserve, and they're like in like 42, 43, and they just do that thing that 40-year-olds do.
Yeah.
Like the I can't remember the last time I triggered somebody before like day 11, much less day 9. So
Well, and you never know as a physician what the right time is, but I think we do know from a lot of research done in Carrie's practice that the bigger the follicles, the better, the more mature they are, the better they fertilize, the better they develop. So I think we would all agree if you're going to go through again, we would push you not necessarily, I mean, maybe not necessarily change the medicine dramatically, just push you a day further or 2.
Yeah. Probably means you'll be a little bit more uncomfortable afterwards because the bigger your follicles are and the more that are big, the more that you are going to feel that. So I would be mentally prepared for,
Yeah.
I'm going to be really bloated. This is not going to be particularly pleasant, but I think there's some serious gains to be made in that. And the difference in your AMH in a year, I've seen AMHs drawn 2-3 months apart that are that far apart. And I think part of the lab, part of it's variation biologically that we don't really have a great explanation of.
Yeah. So yeah, 5 mature says it all right there.
Yeah. A couple more days should help.
agreed.
All right.
Good stuff. All right, next one. Are we going to IVF too soon into a clinic that is 8 hours away? First, thank you for everything you do. All the information and resources have been a wonderful source of comfort for this data-driven gal. My question for you is, are we jumping into IVF too soon, especially considering we are looking at using CCRM Colorado? Feel free to redact if necessary, which is an 8-hour drive from us. Husband and I have been having timed intercourse on and off since late 2020 in combination with some medicated cycles after seeing an RE in late 2021. Unmedicated cycles had luteal phase on average of 9 days, so they've been using progesterone to lengthen the phase. Had 7 unmedicated cycles, 5 medicated cycles, 3 using progesterone, 2 failed IUI cycles. All non-IUI timed so that we have intercourse the day before, on, or after LH surge, or as close to possible. In 2021, AMH was 0.88, but as of June 2022, it is at 1.4, taking vitamin D, prenatal CoQ10, fish oil, and vitamin C. All others levels after an HSG blood work, semen analysis by local RE are considered in range. She is 34, husband is 32. Main concern is, are we moving on to IVF too soon? And have we not given it enough on our own to go on our own? Is that luteal phase length really as much of a blocker as I think it is? We also have to decide between using a closer clinic 2 hours who have fewer protocols available in patients, in CCRM Colorado 8 hours, who in my understanding is one of the best clinics with many protocols available and who see a large volume of patients, but is about 2 times the cost and a much more complicated logistics.
Susan, you probably can speak to that better than anybody. You've been there, done that.
Right. So as somebody who flew across the country to do IVF I couldn't do IVF at the clinic I was working at the time, and I really couldn't go to my competitors who were right next door because that would have been a little awkward. So I chose to go to somewhere like literally across the country. Just based on logistics, if you have an option to do something that is good quality care close to you, don't add the travel into it. Okay. I mean, like, I have a beautiful daughter from the IVF cycle. I am glad I did it. It was a means to an end, but adding that travel and the uncertainty of, like, even if you're doing local monitoring, it's like, when do I have to get a flight? And what if, I mean, I got stuck in a huge, like one of the biggest snowstorms in New York history. And I mean, things like this happen. And if you don't have to go to it, I would recommend considering something closer, as long as you think that you're going to get good quality care there.
Yeah, I think the number of protocols, I mean, I think she's a little, I mean, you could argue that we could do a number of protocols too, depending on how we do the Menopur, how we do the Ovidril, if we add growth hormone. I mean, we're all pretty creative. I think we can come up with different protocols, and maybe we don't publicize that we have all these different protocols, but we do. And so I think, if it's a quality person that's, that's you feel is going to be good for you, I'm like Susan, I don't think I would travel far and wide, because people always have this feeling that the grass is greener on the other side. And a lot of times it really is not.
It just tastes different.
Yeah. One other thing about the protocol, like Abby said, our clinic, when we were automating things, we're like, okay, we're going to write down all of our different protocols so that all we have to do is tell our nurses, do protocol number 1 or 5 or whatever. When we started writing down everything, not even crazy, like, random protocols that we will sometimes do, but just variations on the normal theme. I mean, we were already hitting the 30s and 40s. Just, a dose of 100 is going to be a different protocol than 125, then 150, then 200, and so on. And so the protocols that is a communication thing between the internal staff that is really not terribly different from any other clinic, I don't think. Because the doc is going to say, I want to do X, Y, and Z, and they're going to make it happen. They haven't numbered everything out, which is fine. Most of us don't really need to. You just say, all right, this is what we're going to do. So that happens to work from a logistics method for that clinic. And so that's what they do, which is great. But yeah. And then the other thing is, I have a lot of patients who are traveling long distances to come see me. And there are definite benefits to it. I mean, if you need something that other clinic does that your local one doesn't, or you've tried a couple times and you just need a second opinion, absolutely, totally worth it. But it does add a lot of headache in, and having the last minute flights. And I did IVF on one of my girlfriends recently, and she walked into the airport to come in on a flight, and she had 4 different flights booked for that day. And so the TSA agent was like, which plane are you actually getting on? And she was like, I actually don't know. Let me pull up the boarding pass for the one that I'm planning on getting on. And she showed it to him. But it can be really stressful. So I would agree. Like, if you can get it done close to you, do it. If you need to travel, Lots of people do it. It's
Mhm.
entirely possible.
Yeah, we all have patients that do travel. It's just
Yeah.
if there's an option that will provide you good quality care and you're saying travel because of the name of a clinic and number of protocols, which I totally agree. Like when you start, we have big categories, but then within those categories, we have little subcategories
Yeah.
and things like that. So I would take it with a little bit of a grain of salt.
Yeah. All right. Let's do one or two more.
All right. I was in the middle of a Medicaid cycle for a frozen embryo transfer, estradiol patches, when I went for my blood work and ultrasound this morning and found my ovaries were quiet and lining looked great. But when the nurse called, she said my progesterone was elevated, showing I had ovulated despite what the ultrasound showed. How can this happen? Love your podcast.
Mm. Sometimes it just happens.
Yeah.
I
That's why
mean,
we check it.
yeah, like we're OCD for a reason, because even when we think everything is going perfect and our patient is taking the meds that they need to, and they're doing everything as prescribed, like there's a reason you're in a fertility clinic, and it's because your body is sometimes doing exactly what it wants to do, not what everybody else wants it to do. And that's why we check. I mean, nobody's going to freak out about that. It's just like all right, take your progesterone, get a cycle, and call us, and we'll do it again. And doesn't mean the next cycle is not going to work. Doesn't mean that they necessarily have to do anything differently. I mean, they will. This type of scenario rankles fertility docs, and so they're going to go back and look at your baseline and look at anything you have done since then and your prior records, and then go, all right, does this happen all the time with this particular body, or is this a random one-off? And so they'll decide if they need to do a different type of protocol or change something. But it happens. That's why we check. I'm glad they were checking, and I'm glad that they noticed it before you went to a transfer. Those
Yeah.
are
I mean,
all
that's
good
the
things.
key. Yeah.
Yeah.
It's
So
frustrating for everybody.
the reason why we check it is because progesterone opens and closes the window of opportunity for
Mhm.
implantation. So if you had already gotten progesterone exposure from ovulating, then your window's closed and we could do the transfer and you're not going to get pregnant. And as frustrating as it is to stop, regroup, come up with plan 2, it's much better than not getting pregnant.
Yeah.
Yeah. And we're always disappointed when that happens, when somebody comes in with a giant cyst or their progesterone's elevated or their lining looks terrible. It always makes us feel bad too. We don't want you to have to go back through all that stuff again. It's kind of overwhelming, but we want to give you the best chance. And so, like Susan said, I think the bright side is they figured it out before you had an embryo transfer.
Absolutely. All
Yeah.
right. One more.
Let's do it.
Hi, ladies. I look forward to your podcast every Tuesday. It's really gotten me through the journey this year. I am 32, almost 33 in July, and my husband's 29. We have been trying to conceive for 7 years. Over the course of 7 years, I've done 6 Clomid cycles of timed intercourse, 2 IUIs with letrozole. First one resulted in a chemical pregnancy, HCG of 10, and 1 retrieval that resulted in 5 embryos not tested but graded for AA. I have had 2 HSGs, 1 hysteroscopy, 1 laparoscopy, saline ultrasound. All blood work is textbook perfect. 2 failed embryo transfers with unexplained infertility and slight male factor. Where do you suggest we go from here for our next transfer? What have we missed? We have 3 embryos left. Thank you for all you do.
That's when you start thinking outside the box. And these are things that not all of us would agree on, but we, after 2 transfers of great embryos and there's not a pregnancy, we start thinking, okay, what's out there? What can we do? What can we wrangle? What can we do differently? And that's where some of us would think about doing an ERA biopsy. Some of us would not think about doing an ERA biopsy. Some of us would think about doing a receptiva assay too, although you've had a laparoscopy, and that's really kind of looking for an inflammatory mediator that tends to be associated with endometriosis. You've had a negative laparoscopy, so that probably wouldn't be something that I would think about doing. But that's really the frustrating job or thing of what we do. It's hard to know what else to look at. We just don't know that much about implantation.
So I would also, if you haven't been tested for chronic endometritis, I would make sure that there's no kind of low-grade inflammation, infection going on inside the uterus. Double check, your thyroid function. If you have any other underlying health conditions, making sure those are picture perfect. Okay. Because, we want to make sure that you are as healthy as what you should be. Let's see, anything else, Carrie?
They're not PGT tested embryos. I mean,
Right.
if
I mean,
that's a great point. I
Like,
didn't
the
think
thing
of,
is those first two embryos
That's
could have very
huge.
easily been both
Yeah.
abnormal.
yeah. I mean, if they were PGT tested euploid embryos, then
That's
I would
right.
say do a thrombophilia panel or an RPL, recurrent pregnancy loss panel. Knowing that they're not PGT tested, you could conceivably thaw them and do PGT testing on them. That has the risk of losing them in the thaw or damaging them in the extra freeze thaw process.
But that
Because
risk is moderately low.
We do that a bunch in Nashville, and we've really had, minimal damage. Most of the time, the embryos do great, and they get pregnant with the normal ones.
And when you look at cost wise, realistically, thawing, biopsying, and refreezing is probably going to be the cost of a FET cycle, approximately.
Right.
And
Yeah.
so, if we're wrong one more time, you would have paid for it.
Yeah.
Yeah. So, and that can also tell you if you know you want multiple kids, that may spur you on to doing another retrieval sooner rather than later before you go through a transfer. Like if you know, oh, of my 3 remaining embryos, 2 of them are abnormal, that may push you to say, okay, let's do another retrieval sooner rather than later, go straight into PGT testing so that you've got full family planning, not just for first kid, but for a later one as well.
So Carrie, at 32, what would you tell her statistically about her 5 embryos genetically if she's 32?
At least one of them's normal statistically. Like by the time you get through all of them, you are very likely to get a baby at the end of it. We just don't know, is it going to be on your next embryo transfer or the last available embryo transfer? Statistically, I would say the other 3 are going to be normal. But statistics are great when you're talking about a football stadium full of women. They suck when you're talking about one woman.
Individuals, yeah.
It does not take very much to throw numbers. I mean, if you figure just one embryo in either direction is going to throw out 20% out of 5, I mean, that's a big deal. And so, I think there's probably a baby in there. It's just, can you put your head down, suck it up, and get through that? And do you want to do anything else prior to your next transfer, like PGT, like an endometritis evaluation, like whatever?
Yeah. And I do think this is a good time for you and your partner to kind of sit down and talk about how many kids you do want to have, because I think that is, if you only want to have one-ish kids,
One-ish.
then you may not need to do those other things and consider another egg retrieval and things like that. But if you're sitting here saying, I want to have 3 kids, that's a different conversation.
Mm-hmm. Yeah, very much so. Very much so. All right. Well, to our audience, thank you so much for listening. Be sure to tune in next week for more. Be sure to subscribe, leave us a review in iTunes. We'd love to hear from you. We're on Instagram, we're on Facebook, YouTube, all of those places. So hop on by, leave us a like, subscribe, and say hello.
You can also visit us on fertilitydocs.com to submit specific questions that you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, like today. So don't hold back. We'd love to hear from you.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye.
Bye.